also mention, thank you, Alice. I just wanted to mention that some of the content we're talking about might potentially be triggering, as we'll be discussing death rates and gender-based violence issues. And we please ask that all comments in the chat are respectful to each other and particularly to survivors who might be present in the room. In this webinar, we'll discuss the key findings of the University of Birmingham's research paper, estimating the excess mortality due to female genital mutilation. This is a closed webinar with key stakeholders, and we've identified 3 main aims for bringing you here today. The first is to socialise the findings with key stakeholders. Secondly, we'd like to ensure that stakeholders understand the methodology and feel comfortable using the findings. And lastly, we'd like to increase the uptake and use of these key findings. We wanted to limit the number of speakers to allow as much time as possible for Heather and James to share their findings, the methodology, and to give you, the audience, space to ask questions and to feel comfortable with using the data. With this in mind, we've organised the webinar in partnership with TGG, as we both feel that this data is very important. And later in the webinar, we'll be sharing a statement from Layla from ALM. I'll now hand over to Anush Agarbalan, who is the Head of Advocacy and Policy at Orchid Project.
Thank you very much, Natalie. Hopefully you can hear me. Yeah. Okay, so I'm very excited that we finally have this opportunity to have the webinar. It's been long in the making, pretty much from the moment when we first saw the data published by the University of Birmingham. As Natalie mentioned, we saw this as an opportunity or even a necessity to maximize the reach of these important findings within the sector, to act as a bridge between the academia and practitioners, so to act as facilitators of how kind of this information can flow to key stakeholders and to bring you, who we think is a key stakeholders, to this conversation, to understand the data and hopefully also uptake it. So I'll do a very quick introduction. And believe me, I'm not going to do justice to the kind of the all amazing work that Heather and James have done, but I'm going to quickly read kind of their short bio. So Heather Flowe is a professor of psychology at the University of Birmingham. Her research focuses on gender-based violence, prevention, and response. She collaborates closely with survivor organizations, legal professionals, and various agencies to enhance evidence base and develop solutions that protect survivors' security, health, and well-being. And she also works on tools to help survivors provide their best evidence in police investigations and criminal proceedings. So welcome, Heather. And James. James Rockey is a professor of economics at the University of Birmingham as well. He's an applied economist with a particular expertise in bringing together statistical and econometric techniques with complex and unorthodox data sets to provide policy-relevant evidence. And his recent work applied this approach to a range of topics, including economic gender inequality, the economic consequences of remote working, and political extremism. So thank you so much, Heather and James, and welcome. And thank you for spending and bearing with us in the months of trying to organize this webinar. So without further ado, and I actually wanted to also quickly say how we're going to run through this webinar. So we will give as much time as possible to Heather and James to talk us through the key findings, methodology, have a couple of follow-up questions with them, talk about importance and how we can use it in advocacy, but then importantly, give you a chance to the audience to ask questions about the findings, methodology, research, and then hopefully we'll have time for a bit more of an interactive exercise on Mentimeter if the time allows, but we're going to prioritize the questions because that's really important. Yeah, and I hope I don't talk too fast. So Natalie, you have to tell me to stop if I'm going too fast. And without any further ado, James, over to you. And Natalie, can we please share the presentation? Thank you.
Hello, everyone. Thank you for that lovely introduction, Anush. I just want to start by saying I'm an economist. I am not. I'm an economist from and working in England. So I'm extremely aware of how much I don't know about FGMC, the context in which it happens, the societies in which it happens. And I'm just going to talk about mine and Heather's particular expertise, which is in sort of statistics and trying to learn from the kind of data sets that we have analyzed to sort of develop these results. And hopefully it's useful to you all and the amazing and incredibly important work that you do. So should we move on to the first slide? Okay. Right, so the title of the research paper that we're going to talk about today is on estimating excess mortality associated with FGMC. So the questions are, why are we estimating it, and why are we looking at what is excess mortality? So there is not a lot known prior to our paper, but in the academic literature, I think lots of people know things in other ways about how often FGMC is associated with the death of people to whom it's done. And this is despite the fact it's extremely prevalent. So 230 million women and girls worldwide have been subject to FGMC, but it's inherently quite a private thing, and it's often done informally. So there aren't government records on it in the way that there might be about other things. This informality also means that there are likely to be a higher risk of medical complication. The fact that, often it's done, if not in secret, if not just informally, but maybe also in secret, means that there isn't data. We don't have a big list of where it is done and how often and at what age and so forth. And that means that we cannot analyze the consequences of it in the way that we might be able to analyze the consequences of other problems in society. So what we do instead is we take a so-called forensic economic approach, and I'll talk about what that means in a bit. But it means that we can't measure the impact on any one girl or young woman. We can't know in the analysis that we do what the individual effects are. Instead, what we're going to look at is the excess mortality. So is it the case that in the age groups at which in a particular country FGMC is most common, that we see more girls of that age dying? And so our statements are not going to be about individual women and girls. They're going to be about the population of women and girls in that country in a particular year. And that's in the same way that you might measure the impact of the COVID pandemic, or indeed how the government in the UK measures the impact of a flu season. So there's lots of other things going on, and you compare. You make this comparison at the kind of population level rather than at the individual level. Okay, so we move on to the next slide. Right, and so to not keep you all in suspense, what do we find? We find that just over 44,000 girls and young women die every year due to FGMC. If you divide this by the number of days in a year and the number of minutes in a day, this amounts to the death of a girl or a young woman every 12 minutes, which I realize is about one person in the time that this presentation will take, terrifyingly. And this is clearly extremely sobering and frankly terrifying in its own right. it also means that FGMC is one of the leading causes of death in the countries in which it is widely practiced. So it's, on the same list as malaria and infection and the other big killers of children in those countries. There are lots of things that we're not taking into account in this number that mean it's very much likely to be an underestimate rather than an overestimate. So we don't include later deaths. So if women are more likely to die during childbirth if they've been subject to FGMC, we won't capture that. We won't even capture the death if there are deaths of girls a few years later. We won't capture that either. The approach we take by looking at excess mortality at a particular age means that we can't take into account those extra impacts. And maybe we'll talk about that in the question and answers later. Can we have the next slide, please? Right, so this is a picture from the paper. I don't think, unless you've got a very large screen, you'll be able to read the words on the horizontal axis. But you can hopefully see that there's a dashed line going across the graph, and that's the number of deaths every year due to FGMC. So that's the 44,000 figure. And then the orange or red bars are the number of deaths associated with each other leading cause of death. And so the very highest one is enteric infections. And then the next one along is malaria. And then the final one that's higher than the FGMC dashed line is respiratory infections and tuberculosis. So this means that FGMC kills more children than HIV and AIDS related infections. It kills more people than measles, meningitis, nutritional deficit and related diseases, and so on and so forth. So what the results of the paper really imply is that this is a first order problem in terms of the risk to lives of girls and young women in the countries where it's practiced. Maybe we should move on to the next slide. Okay, so why did we have the idea to do this, and why does it make sense? So, as I said at the beginning, the idea is that one of the problems in providing sort of scientific evidence about the impact of FGM is that when you can't measure it or observe it directly, it's harder to learn about. Now, the Nobel laureate Amartya Sen famously wrote this article in which he said more than 100 million women are missing. And he noted that in various societies, the ratio of women to men in the population was not what you should expect, was not what you saw in countries where he felt that the sort of population ratio was what sort of biology intended. And he added up these ratios, particularly for India and China, but also for sub-Saharan Africa. And it came to more than 100 million women when he wrote it in 1990. And people have been updating this figure ever since, and it's now larger. And this partly reflected the impact of selective abortion. It reflected lower levels of nutrition for young girls and other factors like that. And this idea that we don't need to know what's happening in a given abortion clinic, or we don't need to know what's happening inside a particular family in terms of how they care for young girls versus young boys, but that we instead can look at the outcomes, that if it's the case that more boys than girls are born for some reason, then 20 years later, you might find that there are more boys than girls in the population in a way that otherwise you wouldn't expect. This broader approach to economics and demography has been used in lots of other high-profile research. It's been used to analyze and understand the decisions of Mexican drug cartels, to capture racial bias amongst police officers, or indeed judges, and basketball referees. And this is important because sometimes people don't necessarily know, let alone would admit to being racially biased. They might think they're not, but what we can do instead is look at the outcomes rather than looking or asking them about their decisions. And so we take this sort of broader intellectual tradition and we apply it to FGM. Oh, sorry, can you move on to the next slide, please? And doing that, we end up with this total figure that I told you about. Here, what we have is estimates for the individual number of girls who died in 2019, but it's an average over, it would be, this is an average figure, this isn't 2019 specifically, by country. So the number varies quite a lot. It mostly varies with population. So the Sudan is a much larger country than Togo, but it also will reflect that in some countries, almost all girls are subject to FGM-C, and in others, it's a subset of the population. But we see that these are large numbers everywhere, frankly, and that therefore this is a sort of this is a problem in all of the countries in which it is practiced. And for those of you working in some of these countries, hopefully these numbers are sort of relevant to you. These are, again, as the title of the paper emphasizes, these are estimates. So it is not the case that we know for certainty that in Chad in 2019, there were 872 extra deaths to what there should have been. You can rather, it could have been more, it could have been less, but our best estimate is that it's 872. And as I said before, that's a conservative estimate. That's probably the lowest, that's the smallest number that we think is sensible. Can we move to the next slide? So how do we get these estimates? How do we work out how many extra deaths there were in Chad, for example, or Nigeria? So what we need is some good data on mortality rates and on the prevalence and age at which FGM-C is typically performed. So the UN Population Division has really quite sophisticated data that tells us the number of people alive in a given age group by sex in each year. And so by subtracting, essentially, we can work out how many fewer 5-year-olds there are than 4-year-olds, and so on and so forth. And this gives us a mortality rate for each age group. And then we can relate that to data from the DHS survey, which is this sort of gold standard survey of health and various other things run all over the world in low and medium income countries, on which asks women whether they have been subject to FGM-C and whether their daughters have, and if so, at what age. And this is important because we're going to need this variation in the age to do our estimates. Maybe the next slide. So what we are then basically asking is, how does the survival rate of girls of a particular age to the next age? So the survival rate of could be newborns into their first year of life, or 5-year-olds until they're 6. How do patterns in those survival rates match up to patterns in the percentage of girls and young women in those countries that are subject to FGMC, and the age at which they do it? So is it the case that we see higher rates of mortality amongst girls at the age at which it happens in that country? And the answer is yes. And but it's not. What we do is more sophisticated than that, because obviously lots of other things are going on. Firstly, sadly, in many countries where there is inadequate access to sort of good healthcare, the mortality rate is already very high. And we want to take that into account. Secondly, war is also a big cause of the deaths of boys and girls in many places, particularly in sub-Saharan Africa, as is crop failure, disease outbreak, and other sources of sort of income difficulties. So we might want to adjust for those things, to take them away and say, even putting that to one side, does the pattern still remain? And then secondly, we might want to take into effect, so we can do that by looking at the mortality rate of boys of the same age in the same year. So if you had a pair of twins, for example, one was a boy and one was a girl, they will be exposed to roughly the same experiences. And so by looking at that, we should be able to adjust for those experiences that both the boy and the girl experience. However, girls are different to boys. They are more robust. They are less likely to die at all ages, basically. And so we need to take that into account. And so we do that as well, statistically. And then we also take into account the fact that that trajectory, so the age at which people, the risk people face in the absence of FGM varies by country as well. So doing all of that, we are getting rid of everything else that we think can be going on that's driving this pattern. And we're just leaving the pattern in FGM, ages and shares, and the pattern in excess mortality. And that is where our number comes from. And I think that's probably next slide. Yeah, and we won't talk about that unless someone really wants me to.
I'm unmuted. Yes. Thank you so much, James, for this detailed presentation. I had a lot of questions lined up, and I think you've answered quite a lot of them already. So thank you for sharing this. I have a few follow-up questions that I still want to ask, but I thought maybe before we go into kind of deeper dive into the kind of research and findings, is just a bit more personal question to you and Heather, is why did you choose to look at this topic? You being an economist and Heather being a psychologist, so why this particular topic? Why to focus on FGM? So it just a bit to give us an insight of why did you decide to work on this?
Okay, I'll be happy to start. Thank you so much for having us. It's a real pleasure to be here today and to speak with everyone about our research, and we look forward to hearing what you think about it. So I've been studying gender-based violence for about 20 years. As you could tell, I'm from the US, and I began my career looking at how the criminal justice system handles or doesn't handle the investigation and prosecution of sexual violence. And that led me to do lots of research in laboratory conditions, trying to understand things about human behavior, test theories about human behavior. But I always go back to the real world, looking at real world data to try to get an understanding of how things are actually working in people's lives, and particularly in when it comes to gender-based violence, how people who are being subjected to violence cope or don't cope with these experiences, and trying to understand how we can support people in healing and achieving justice, whatever that looks like from the perspective of a survivor. And as parents, for full disclosure, James and I were married. We have 2 daughters, and we feel that it's really important to leave the world in a better place than we found it. So it's also very personal as well. And I guess from a professional perspective, we're just really interested in some of the challenges that come up in trying to measure how often these violations are happening to people, particularly because we're talking about situations all over the world where there's limited data, there's limited investment in data, where governments don't want to know that there are problems, and so there's little investment in obtaining information about the problems that people are experiencing. And so as researchers with skills and statistical approaches and research methodology, we're really intrigued about the possibility that we might be able to utilize some of these innovative statistical approaches that James talked about to be able to shed light on what's happening in the world, where we are missing data, where we're missing girls, where we're missing women, to be able to understand more about these patterns of gender-based violence. And once we understand them, then we could respond to them and then we could prevent them. And the focus of our work in recent years has really shifted to working with survivors, to work with these organizations that want to be able to understand where these statistical approaches come from, where the data can be captured. And then through training and co-developing projects, we could develop together innovative methods to start to capture what is actually happening on the ground. And so through kind of our research and trying to work with survivors organizations to measure these societal problems, we started to talk about how these statistical approaches that have been around for some time in other arenas could be brought into other fields, such as FGM. And through some work with the Orchid project, through a colleague of mine, Sean, that really kind of raised awareness in our minds more about FGM. And there's a number of researchers at the University of Birmingham who also work on FGM. So through professional contacts and through our own kind of motivations to want to empower and work with survivors so that they can understand the data, so that they can capture the data, so that they can go to duty bearers and acquire the budgets and the resources and the things that are needed to truly shine a light on what is happening on the ground. We wanted to be able to contribute to that. And so we're really pleased again to be here today to be able to share these results with you.
Thank you very much, Heather. That's quite explanatory, so thank you for sharing. I'm very conscious of time, so I want to ask a quick follow-up question. And James, you've mentioned kind of on the screen the countries where the research has been conducted. So I wanted a quick follow-up question in terms of why did you choose those countries? Why, and for example, why Somalia, Somaliland, where the FGM rate is pretty much near universal, why, for example, Somaliland wasn't included, and why the specific choice of countries in this research, and that's okay.
No, absolutely. So I mentioned the data that we used. So we used the DHS and we were limited by the UN population data is available for everywhere, but the DHS data are not. so we could only do that approach for countries in which they had run the particular module of the DHS that asks the FGM questions. And that doesn't include, for example, Somalia. In the research, we also ran our statistical analysis for an expanded list of countries where we use, in fact, Orchid project data, or data that, so we use all available estimates. And that does include Somalia and Somaliland, but it doesn't, those data are not in every case as precise because they don't tell us the distribution of ages, they tell us the most common age. And so in general, we prefer to, because in scientific research, you have to be very cautious. We prefer to use the DHS data where we can say, these are data that everyone understands. We can explain very clearly how we got them. But we find the same thing. We find the same sort of terrible pattern when we use the broader data for 25 countries in total.
Thank you, James. And another follow-up question around the countries is, what does this research then mean for other countries that have prevalence rates of FGM, but they were not included? And can we extrapolate the existing data to other countries where FGM is practiced?
I could handle that. I'll handle it succinctly, just to say that in the absence of the other data, we're not able to make sound conclusions with respect to what the mortality levels are like in those countries. And indeed, it's even challenging to be able to make predictions about the future because there are so many variables that affect mortality that are changing over time, such as access to healthcare and so forth. And so we want to be cautious about extrapolation, though with further study and as data become available, it will, of course, be possible to update our results.
Thank you, Heather. And since you mentioned further study, what, if any, further research do you think is required or might be helpful after this one? Because I think we'll be looking to see what else could we do with the data.
Yeah, thank you. Just a couple of possibilities. I mean, first, we would like to be able to address the question of excess deaths that happen over time. So looking at what happens to a girl as she ages and gives birth, and looking at mortality around that, I think is something that we are thinking about so that we could look at this more comprehensively. I think it's also really important that we take a human rights lens to our research and that we think about how to analyze this interdisciplinarily, looking, for instance, at the impacts of trauma intergenerationally, on cycles of violence, on poverty, on people's access to education. All of these things have to be considered simultaneously. In addition to death, FGM causes so many other societal and interpersonal and individual miseries that we need to be able to look at this comprehensively to really and truly make the difference that we want to in policy and in people's lives.
Thank you, Heather, very much. I mean, I have so many other questions, but I think I'm going to keep my questions to myself to allow more time for the audience.
Okay, and I think Anoush, just hearing the the research from Heather and from James, if it's possible, it would be great for me just to ask you a quick question from an advocacy perspective, because I think there's people in the room who will be interested in hearing that. So why do you think this research is a game changer for advocacy work, and how does this study change or add to the existing understanding of FGMC and its risks?
I don't even know how to answer it shortly, Natalie. So I think it should be a game changer. So firstly, I think what it does, it shifts the narrative around female genital mutilation and cutting. So it reframes FGMC from a harmful cultural practice or tradition, as it's called, to life-threatening practice, to an epidemic that contributes to global child mortality. I think that's what hit me the most. And the new data should help us to elevate FGM as an urgent health emergency that requires immediate global attention. So, and if you look at the numbers that James shared, a girl every 12 minutes, if it's not kind of dies every 12 minutes, if it's not an emergency, then I wonder what is. So, and I think there can be a massive potential in this to reframe how we talk about FGM, how we use it in our advocacy work, and how we need to change the case for support as a sector. So I know that ALM and the Girl Generation team really likes to talk about the power of language. So I'm going to mention here how it's really important, kind of the power of language. So when we look at the language around FGM, and we can see how it changed and evolved throughout the years. So even about a decade ago, FGMC was seen as an issue present predominantly in Africa, was siloed into a so-called niche of a cultural practice tradition that happens in one region only. And since then, there's been so much kind of broader recognition of the practice as happening in Asia and Middle East, in over 90 countries in the world, among immigrant population, but also how the language around it reframed to recognize it as a gender-based violence and a human rights violation and not a cultural practice. So this shift in language and kind of more widely available data and evidence has helped to elevate FGMC more prominently on the global agenda, on including it as an indicator in the Sustainable Development Goals. And that's why I think this data and the numbers that the findings reveal are important to, again, reframe what FGMC is and how we push it further up the agenda. So for me, that's the key thing about global kind of changing the narrative. I think secondly, it also introduces a sense of urgency, a new sense of urgency that the issue deserves. We have data that shows FGM is not only a human rights violation, but a significant risk to life. So, and it should strengthen our position in international and regional spaces to demand a similar level of attention that other preventable causes of mortality do. So this is how we need to do that. That's the question. And then I just want to go back to the first time when about a year ago I saw the findings of the University of Birmingham research, and my first reaction beyond the shock of the numbers was how this can create the sense of urgency, and that's kind of as a life-threatening practice, and that's why we decided to do the webinar. And then finally, again, we all know that we are in a critical need of global funding, so we know that the sector is underfunded by about 2.7 billion only in the 31 high prevalence countries. I'm not talking even beyond those countries, to end the practice by 2030. So, and if you are advocating in global spaces of influence or regional spaces of influence, you know how difficult and crowded the spaces are, because as a sector you compete with other sectors, with other issues for funding. And at a time when funding for women's rights work is dwindling, it's a very important argument to use that FGM is a leading cause of death. And hopefully it will help us to bring more funding to the sector. So.
Thank you, Anoush. Sorry, I gave you quite a long question to answer in a short amount of time. And I think now it would be great if we could just move over to some questions that the audience have asked. So this one I think would be for Heather or James. Please feel free to answer whoever feels most comfortable. But someone has asked, is there a reason that multiple indicator cluster surveys were not considered in addition to the DHS to expand the country list?
I could answer this if you would like. So we went with the DHS because it might not have been the right choice, but when we looked into it, it seemed like it was the data source that had the most consistent data, and in particular allowed us to recover the age at which and the incidence of FGM, which was important for the way in which we estimated the excess mortality rate. In terms of expanding the country list, I mean, we then did that sort of maximize the sample by using the kind of data tabulated by Orchid and indeed also UNICEF. I think we could. I mean, one could do it with other data sets conceivably, but from the point of view of getting it through the kind of academic publication process, what we want is they want arguably different things to what advocates want. So they would sooner a smaller set of countries for which the data are really good than a kind of larger set of countries, and rightly or wrongly, perhaps wrongly. So that's why we went with the DHS data. Yeah, maybe we should think about the mix for future work. Thank you.
And I think it's really important to highlight that I think first, this is just the beginning. We're really grateful to have this research here. And I think, Heather and James, you've acknowledged that you're really keen to kind of move forward and get more research as well. So we are really grateful for what you've given us as a start. And I think we've got more of a comment here. I don't know if you want to respond either, from Wizzle saying FGM types or severity and consequences vary to death. Treating consequences equally and using population size may drive estimates upwards.
So the one graph that I didn't include in my big pile of graphs is we were worried about that. It is something I think we would like to understand more in future research, more precisely. What we did is to make sure that no one country was swaying our results. Firstly, we report the results weighted and unweighted by country size. So when you weight by country size, the largest countries, say Nigeria, are going to really have a bigger impact on the research than, say, Togo, which makes sense at some level. But you want to make sure that no one country is sort of responsible for our findings. And we do that by also not weighting by country size, and then also by rerunning our estimates, leaving out one country at a time. We can also leave out 2 countries at a time if you want. And what we find is that gives us a way of checking that what we're finding is not driven by one country, perhaps where a particular form of FGM is most common, or the age, or a particular age group, or whatever, and we don't find that. So the results suggest that that isn't what's responsible for the results we report. That isn't to say that there isn't good reason to believe that more invasive forms of FGM-C are likely to have greater consequences, but there will be other things going on as well. So it's also the case that the circumstances in which it's performed will vary across country and indeed within country. And those are the kind of things that we'd like to get at in future research, but that will require more data, basically.
Thank you so much for that, James. And we have a question from Stephanie, who works at the World Bank. She said, we work with legislators, policymakers and communities on the prevention of FGM. Is it possible for the authors to provide a table by country of the prevalence of FGM alongside with the excess deaths? This would allow us to provide estimates to the countries in which it was not calculated. For example, in the Gambia, FGM is practiced at X percentage. We can inform them of the excess deaths in countries with similar prevalence rates.
Yes, so we have we have in the paper the table of prevalence rates, and I can join that with the table of estimates of excess mortality easily. So I will do that. That's no problem.
Though I should add that it should be caveated because there's factors within a given country that could affect the degree to which that estimate is applicable, and the estimate could either be higher or lower depending on the characteristics of healthcare and so forth in that country. So that I think there would need to be some sort of sidebar to accompany that table so that people were aware of some of the issues that come up in extrapolating.
Thank you for that. And let's see what other questions we have. Sorry. So the last one we have is it possible to estimate the death rate for FGM, e.g. per 100,000 girls?
Yes. So in the paper we provide results in terms of the absolute increase in mortality rates, and you can essentially multiply those by 100,000 to get the death rates per 100,000. Yeah, I can't do that off the top of my head, but yeah, that would be a very straightforward number. So if you want that, let me know. I will provide. Happy to. And indeed, and I mean, in general, if there are numbers that would be useful to anyone in the context of their advocacy work or further research, whatever it would be, that you think that Heather and I might be able to provide based on this research, we're very happy to do so. Just be in contact with us either directly or via Natalie and Anush, and we can do we will do what we can.
Thank you, James. And then I think just the final question before I hand over to Anush for the closing. We have a question from Anne-Marie, and she said, how do you deal with the sensitivity of African taboo of suppressing death in FGM figures?
So this is a sort of exactly the reason why we take the approach that we do, that this is not the kind of thing that you can go and ask people. They might not know, firstly, because it might not be obvious to them that you can link. I know that there's been recent stories in the Gambia, for example, where they were, it was clear that there was a link. But in general, especially with, say, young infants, you wouldn't necessarily know. And secondly, you might not be willing to talk about it. Or you might choose to convince yourself that it wasn't true. Lots of things could be going on. The census data are, if you read the incredibly boring appendices to the census, the population figures we use, they are reasonably confident in them. And people, new people are not born age 6. I mean, everyone is born age 0. And so by looking at these kind of gaps in the population, we're able to get around that problem. The kind of looking at excess mortality allows us to sort of circumvent that taboo and to reach these numbers.
Thank you so much for that, James. And sorry, just for James and Heather, one final comment, and then I promise we will go to closing. So Wizzle has commented, as a medical doctor, it's not convincing to treat FGM severity equally. FGM survivors have an intersectional issues going on, lower SES, etc., that could contribute to morbidity or mortality. It's difficult to determine FGM as a main mortality cause.
I think it is the case that you can't know that FGM is the cause, for certain, in the way that you could if you were able to run one of sort of Heather's laboratory experiments. And, the paper is quite cautious about that. Having said that, I think it's hard to come up with an explanation that is based on social class or other forms of deprivation or inequality that has this particular coincidence with the age at which FGM is performed. So there are, of course, other things going on, such as there may be a recession or an outbreak of some other disease or whatever else that might be expected to lead to higher rates of mortality. And that will affect the poorest in a society more than those who are better off, and that's true in every society. However, you have to work really quite hard, and I would say implausibly, to come up with a version of that argument that across all of the countries that we study, and no matter whether we leave some countries out or whether we include the broader set of countries, and we treat the data in various different ways in the paper to kind of really try and be as convincing as possible, that you still find this pattern in the data. I'm certainly not aware of any other kind of consistent explanation that one could come up with.
I would also remark that the data are from 2 decades, so it'd be difficult to really find a way to argue that there is an alternative explanation that withstands the arguments that James just articulated, but also at the same time, it holds not only across countries, but across the years, where we see at the ages at which FGMC is practiced, that we see the difference in mortality between boys and girls and against probabilistic expectation.
Thank you so much, James and Heather. Sorry, I'll just hand over to Anoush finally. Thank you.
Thank you very much. I can see there are more questions coming in, but unfortunately we are a bit short on time to respond to all of those, which kind of shows why this research is so important and why it's so critical to have conversations about this. Before we close, I wanted to quickly read a quick statement from Leila Hussein, the Girl Generation Global Advocacy Director, who couldn't be with us today, but just a quick one from her is this: the data we're discussing today makes it undeniably clear that FGMC is far more than a cultural or social issue. It is a severe public health crisis that leads to the loss of innocent lives. We are confronting a pandemic of violence against children. The stark statistics on girls dying from FGMC expose the gravity of violence and call for an urgent, decisive response. This research reframes FGMC from a so-called harmful cultural tradition to a life-threatening violence, underscoring that every recorded death is a preventable tragedy. It is imperative that we prioritize the collection of data on the death of girls due to FGMC. These statistics are not just numbers, they represent the stories of children lost to brutal violence. By collecting and utilizing this data effectively, we can drive meaningful advocacy, push for stronger policy measures, and hold governments accountable for the safety and well-being of girls. So thank you very much, Leila, for providing that comment. Hopefully you're on the other end listening, but it sounded like Leila's message is also a very good closing remark for us for this webinar. What I think I want to acknowledge that this is just the beginning. I think this is such an important data that University of Birmingham produced that could be used, and also thought about what could be the next step for us in terms of usage of this data, of pushing the governments, pushing the donors to acknowledge the numbers and to do more. So it's a call for action as well for those on this other side of who are listening. So thank you very much again, James and Heather. It was really wonderful to have you. And thank you for the research that you have done, which brings such an important data to the community where it's really needed. Thank you everyone for listening. Sorry if we haven't answered your questions. We'll try to collate them. And if there is a chance, we can probably go back to them if your data and emails are shared and hopefully come back to you with that. And thank you, Natalie, as well for supporting us with all of this. Thank you, everyone, and have a good afternoon, evening, morning, wherever you are. Thank you.
Thank you.
Thank you.